I'm your host, Dr. Jack Braha, and welcome to the Medcast Plus show. On Medcast Plus, we feature your local community physicians and healthcare professionals who are experts in their field and who will share their experiences and knowledge. I invite you to visit our website, medcastplus.com, and follow us on social media. Today, our guest is Dr. Ilya Blokh. He is board certified in internal medicine, hematology, oncology, hospice, and palliative care. As you can tell, he's a pretty important and well-trained individual. He has been in practice here for over 10 years and has been a part of the Brooklyn landscape for quite some time before that. I am honored to not only have him here on the show, but also to work with him. Dr. Blokh takes care of my patients at times, and I work with him at some of the local Brooklyn hospitals. Today, we will discuss a few topics related to hematology, the study of the blood. Also, it is March, and that means Colon Cancer Awareness Month is upon us. We will discuss how we can prevent colon cancer and touch on how it's treated and detected. Welcome to the show, Dr. Blokh. It really is a superb honor to have you here. You have been a part of Brooklyn Healthcare for quite some time. Welcome. Thank you for coming.
Thank you, Dr. Braha. It's
So
a pleasure to be here.
Tell us a little bit about where you practice here in Brooklyn.
So I'm on Kings Highway, right in the middle of Brooklyn. It's nearby Mount Sinai Hospital of Brooklyn and Community Hospital of Brooklyn. The practice is pretty much a general hematology-oncology practice. Treat the most common types of anemias, problems with the white count, platelet count, problems with colon and breast and leukemias, pretty much the common maladies that affect people as relates to hematology and oncology.
Right. So as a hematologist, you study the blood, we treat blood disorders, and as an oncologist, which is the study of cancers, tumors, this is not only cancers that we think of like tumors that grow in our colon or in other parts of the body, but also blood type cancers as well.
Correct. People think oncology is simply cancers of solid organs, but unfortunately people get cancers in the blood. It could be cancers of white cells, cancers of red cells, cancers of platelets. So there's a whole array, whole gamut of different types of cancers that people could have.
And this is what you take care of over on Kings Highway in Brooklyn.
Yep, I'm proud to be in Brooklyn. It's a wonderful place to work, very diverse population, and I get to really meet people from all walks of life.
Brooklyn is the incredible melting pot. I agree with you. I enjoy practicing here. You see everything in Brooklyn. But before we delve into hematology and oncology, let's learn about Dr. Blokh. I know you weren't born here. Where were you born?
Actually, I was born in Kiev, Ukraine. Came here in 1979. At that time, we had communism, so there's a whole different type of life living in the former Soviet Union. And I got to thank my parents for bringing me here because there's nothing like coming to America and living in New York.
So 1979, you arrived. Did you come straight to Brooklyn or did you go somewhere else?
Well, actually, there were no direct flights at that time. So we had to first go to Austria, then Italy, and finally to America.
And then you arrived here and in Brooklyn. You went to school in Brooklyn, right?
Yes. I consider myself essentially a Brooklyn guy. I came here, I was 4 and a half. I went straight to Canarsie, grew up in the Bayview houses there, and went to public schools literally from kindergarten through medical school.
So you were really Brooklyn bred. And so you went to Brooklyn Elementary, Brooklyn High School.
Brooklyn College.
Brooklyn College, but I understand that you were so smart that you were accepted directly into medical school, essentially.
Actually, it was a special program from high school that took students in a combined Brooklyn College, SUNY Downstate. So I kind of got the best of all worlds. I got a chance to get into medicine, and I got a chance to experience the public school system and the state system by going to CUNY Brooklyn College and SUNY Downstate.
Both excellent
I'm very proud.
Educational resources here in our institutions here in Brooklyn. So you went to Brooklyn College, you spent some time there studying the pre-medical courses, then you moved on to Downstate.
Yeah, actually in Brooklyn College I studied political science. I kind of wanted to get a little bit different feel for things other than medicine. So I studied political science at that point, and then I went to SUNY Downstate.
Yeah, I agree with you. In college, it's important when you know you want to be a doctor to not just focus on science and science and science. You have to be well-rounded. So you studied political science, which probably helps a lot in these days right now. But you then went on to Downstate. How does someone decide to become a hematologist-oncologist? Because, when we talked maybe before we were in medical school, the word cancer was always cancer. it was whispered amongst people. You know, thinking back to Neil Simon's plays where, you know, he gets on, one of the actors on stage would whisper cancer because it was such a bad word. And it still is, and it scares people. And to move into this field where, you know, people are just so frightened by the diagnosis, how does one really build up the courage to go into hematology oncology? What made you decide to do this?
Well, I kind of wanted to be a doctor from many, many years, literally since, I would say, high school, junior high school. But specifically, hematology oncology was from downstate. I had these old-timer professors, and you know, they kind of practiced old-fashioned medicine. They would come to the bedside, they would actually examine the patient from head to toe, the eyes, the ears, everything. And my best mentors were hematologists, oncologists. They were kind of tough doctors, tough on the students, tough on their residents.
Did they beat you up with the questions on rounds?
No, but they made their residents cry.
They made their residents cry.
They were really tough, but at the same time, they were tough because they wanted the patients to get the best care. They would always say that they were advocates of the patient, and they really advocated for their patients. In SUNY Downstate, Kings County, they made sure everything was done for them, and I really respected them, and they really inspired me to go into the field.
Yeah, I think that's true of all of medicine, that our mentors have a huge influence on what we end up doing in our lives. Same with me, with my mentors, watching how they practice. I still try to do that. And I can tell you that for our viewers today, Dr. Blokh, who's a hematologist, oncologist here in Brooklyn, does that amazing bedside care. I've seen him interview patients. He takes a history. He finds out everything about his patients because it's important to know everything about our patients. And so you went into hematology oncology. Where did you train?
Well, I trained in residence at Long Island Jewish, and from there I had the pleasure of meeting Dr. Rai, who developed the famous Rai classification for CLL. And Dr. Rai, I mean, pretty much is friends with almost everyone in the field. So through him, I got a chance to travel and meet some of his friends. So I went to St. Vincent's, the Royal Marsden in London, and met a lot of his friends, and they really, really inspired me further on. And from there, I knew that I wanted to do a fellowship in hematology oncology, which I did at Stony Brook.
So you're out in Long Island at Stony Brook. You spent how many years as a hematology oncology fellowship?
3. It adds to the 3 of residency, so that's
and
6
the 4
already.
of medical
And
school.
Exactly.
So 10 years after college, still spent training into this field of hematology oncology, and you are board certified in 4 specialties: medicine, hematology, oncology, and palliative care, hospice care. Quite an accomplishment.
Oh, thank you. Well, the hospice palliative care, they don't really teach a lot of that stuff during training, and I felt that to be a good oncologist, you really need to know a lot of things that are taught in hospice and palliative care. Looking at the patients from a biopsychosocial model, treating their symptoms, some of the ethical issues involved, end-of-life care. A lot of these things are emphasized in hospice palliative care, but not necessarily in hematology oncology training and fellowship. So I really wanted to kind of get a little more experience with
that well-rounded training and approach to cancer care is so important, because many times patients with cancers are not able to cure the disease. They're able to battle it. But a component of that care, at least I see with my patients, has to be what you just brought up of end-of-life care, and really creating a plan for the patient, you know, a whole person plan of treatment, battling the disease. And what happens when we realize that, hey, the end is not going to work out how we expected, and providing that care that you're board certified in?
Well, what they say about hospice palliative care, it's family care. It's really geared towards the patient and the family. It's respecting the family's wishes, the patient's wishes. It's realizing that once the cancer can't be cured, it's very important to treat the patient's symptoms, make sure they're comfortable, and really knowing what the goals of care are for the patient. Often I also have to differentiate between hospice and palliative care, and the two are similar but not quite the same. So hospice is really when we decided we're not going to treat the cancer aggressively, that the cancer is terminal, the prognosis is under 6 months, and really the patient and the family decide that they weren't going to pursue aggressive treatments.
Aggressive meaning chemotherapy.
Exactly.
Or surgeries.
Exactly. But palliative care is symptom control. It's recognizing that you could actually still treat the cancer, but not to forget about the symptoms. Patients getting chemo, radiation, getting all kinds of procedures, they could have nausea, they could have shortness of breath, they could have bowel problems, they could be in pain. And palliative care addresses the symptoms, and you actually can be treated and can receive palliative care.
This is all part of the what we consider comprehensive cancer care, correct? This
Correct.
is the 360 model of identify the disease, how are we going to treat the disease, how are we going to treat it within the goals of the patient. Not everybody wants to go for chemo. Some patients just want to be made comfortable, and so you provide that 360-degree full circle type of comprehensive care. Let's move on to some of the conditions that our viewers might be thinking about. We're here with Dr. Blokh, who's a hematologist-oncologist in Brooklyn. And one of the most common things I see in my practice as a gastroenterologist is anemia. People come to me with low blood counts. They want me to figure it out because many times it's from bleeding in the belly or bleeding in the colon. But not always. There are many, many different causes of anemia. And I want you to explain to our viewers, first of all, what is anemia? They hear it all the time, but what does it really mean for the layperson?
Well, anemia simply refers to low red count, low hemoglobin. It could be either causes destruction, where the red cells are being destroyed. It could be an issue of production. They're not being made by the bone marrow. The bone marrow is the part of the body that actually makes the red cells.
And where is the bone marrow?
The bone marrow is in the bones throughout the body, but the biggest sites are usually in the sternal area and in the hips. And that's why when we assess anemia and the cause is not well known, we do what we call a bone marrow biopsy. We go into those parts of the bone that make the red cells.
And you do that yourself, correct?
Yes, I do that, or what I do is actually also have the radiologist do that. And the unique thing about the radiologist doing it is the patient's not in pain. They give anesthesia, and a procedure that used to be very, very painful, the patients don't feel anything.
So now one of the tests that you do routinely when you cannot figure out why somebody is anemic is a bone marrow biopsy, and it can be painless. It could be a painless test.
Correct.
Okay. So tell us, what are some of the main causes that you see in your practice, especially here in Brooklyn for our patients in Brooklyn? What are some of the most common causes of having anemia or a low amount of red blood cells?
Well, for younger patients, especially menstruating females, the most common cause is iron deficiency from heavy periods. I mean, women bleed every month, and then when they're heavy, that's a cause of iron deficiency anemia. Now, once you get to middle age for women, very important to rule out bleeding from the GI tract, meaning from the stomach, from the colon, anywhere literally from the mouth to the anus. In men, it's always ruling out a bleeding source. That's always the main thing I want to not miss, and I check that by checking iron level. If the iron is low, that means they're losing blood somewhere. Usually.
So the gastrointestinal tract, meaning anywhere from the mouth down to the rectum, we can be losing blood from things like ulcers or cancers or blood vessels that are abnormal. What are some of the other parts of the body that might contribute to blood loss?
Well, anyone who's bleeding anywhere in the body could get anemic. For example, I've had patients where they have iron deficiency anemia, and they are checked. They get endoscopy, colonoscopy, and there's still no evidence of bleeding. So we do a CAT scan. We look for any kind of bleeding masses. People bleed from kidney masses, from any other source.
So with the kidneys and the urine, you check the urine for blood?
Correct.
Right.
It's a simple blood test. It's a simple urine test.
So the gastrointestinal tract, urologic tract, these are sources of bleeding which can lead to anemia. What else can cause anemia? You mentioned that there is a problem with producing or a problem with destroying. So the body is always in a flux of making blood and removing the old blood cells. What are some of the disorders that can lead to problems with making the blood or destroying the blood too quickly?
Right. So the iron deficiency is when they're losing blood from bleeding or rarely from not absorbing. If it's an issue with the bone marrow, there could be blood cancers. For example, there are cancers like MDS, which is called myelodysplastic syndrome. This is a cancer of the bone marrow. It's also called pre-leukemia.
So this is a cancer of the factory where the bone marrow is making our blood cells.
Exactly. The cells are made immature. The cells are not normal cells, and the hemoglobin production is diminished.
So that would be diagnosed by a bone marrow biopsy?
Correct. The bone marrow biopsy actually goes into the bone marrow. We get to look at the cells under the microscope. We get to run specific cytogenetic studies, genetic studies on those cells, and they really could home in on the cause.
So what are some of the causes of too much destruction of blood cells?
Well, destruction typically is seen in autoimmune hemolytic anemias, or any kind of hemolysis or destruction in the blood.
Hemolysis is the lysis, the breakdown of the blood cell.
Correct.
And this can occur with?
So it could occur with antibody production, where the body has its own antibodies against the red cells.
So the body is actually attacking the blood cells.
Exactly. It's an
Okay.
autoimmune process, meaning the
Right.
body itself is destroying the red cells. And the way we treat it is with steroids, which kind of try to slow down and calm the immune system. And typically, it is an effective treatment. Sometimes you get destruction from mechanical valves. That's another cause.
Those are the valves we're talking about in the heart that
Correct.
people get. Right, so what happens with the mechanical valves in anemia?
Well, as the blood circulates through the heart and it hits the valves, there's a certain kind of shear and destruction of the red cells. And that gives a destructive process that could cause anemia. Sometimes it could actually look like autoimmune hemolytic anemia, but the difference is there's no antibodies from the patient's body destroying the red cells. It's the valves that are
Right,
destroying.
so those antibodies are things that our body produces that abnormally will start eating up or causing our cells to be eaten up. So we talked a little bit about blood loss that can cause anemia. We talked about problems with the bone marrow that doesn't produce enough blood cells. We talked about the body destroying too many blood cells. These are all things that can lead to a low blood count, and you can help them as a hematologist diagnose and treat these issues.
And make them feel better, because patients with anemia don't feel well. They're tired. They feel like an elephant is standing on their shoulders. It's like walking with weights on you. You just have difficulty moving. People get palpitations. People get headaches. They get chest pain. Because remember, blood, it has oxygen. Blood carries oxygen. When you have low oxygen, the parts of the body that are muscular require oxygen.
Right,
so the
so
heart is a big muscle.
Not enough fuel in the tank to give energy or oxygen, in this case, to the vital organs.
Correct. So people who already have some heart disease or poor circulation to the heart, now you cut down the amount of oxygen the heart is experiencing, they'll get chest pain. They won't feel well. And anyone whose hemoglobin drops too low or too quickly, they're going to have more symptoms: shortness of breath, fatigue, tiredness, all these things. And
Right.
it's a big effect on the quality of life, getting back to what we talked about earlier. The quality of life, how happy people are and how miserable they are, depends on the hemoglobin.
Right, so things to look out for the viewers are weakness, fatigue,
Paleness.
dizziness when you stand up, and some signs of bleeding. If they're bleeding in the intestinal tract, could be black or bloody stools. Their poop can look abnormal. So it's important that you touched on some of those signs of anemia, especially that fatigue and weakness that folks should definitely see their physician if they're experiencing. There's another big topic out there I want to cover today for our viewers, because we hear about it a lot. We've heard about it with celebrities or people in the news who have suffered from what we call DVT. And we see commercials all the time with famous celebrities on TV talking about how they're on a certain blood thinner, some of the newer blood thinners that are out there. And DVT, which is deep vein thrombosis, a big blood clot that can form in our veins, can be tragic. It can actually kill people, and we've seen this before. Luckily, with technology today and people recognizing some of the symptoms, we can treat them for this. Tell us, what are some of the signs of a deep vein thrombosis, a clot, a blood clot somewhere in the body?
Well, sometimes there are no signs. Sometimes patients may have blood clots and not even know it, and it can cause sudden death when the clot in the feet travels to the lungs. That's how it kills you, by traveling to the lungs. When you do have signs and symptoms of blood clots, typically it's pain and swelling in one foot versus both. Now, you could have swelling and pain in both feet, and that's even worse, because that could be a sign of having clots in both of them. And also, if the clot comes to the lungs, they'll have symptoms referable to the lungs. Patients would have trouble breathing. They may get chest pain. They may get passing out. And usually when it travels to the lungs, it's an emergency. They really need blood thinners. And it's also important to understand that the blood thinners that we give, they don't dissolve the clot. They just prevent more clot from forming. The only way to actually dissolve a clot is a medicine called TPA, and that's rarely used. The typical drugs we use are to prevent further clot.
Right, so if someone has some of the signs and symptoms you described of a deep vein thrombosis, of a blood clot, is a swollen or painful leg, could be both legs, shortness of breath, God forbid, if this is traveling to the lung. As you said, that's an emergency. People can die of this, and that's what we see. Sometimes folks are on a long airplane ride, they stand up, they start walking off the plane, and down they go. And one of the first things you have to think of is a blood clot. So what are some of the causes of a blood clot, of a deep vein thrombosis that we just talked about?
Yeah, well, sometimes there's hereditary predispositions. So when a patient comes to me with a blood clot that comes out of the blue, in other words, they didn't have surgery, they weren't lying in bed for a long time, they didn't have an injury to the foot, then we start working up a genetic predisposition.
Meaning that they inherited some disorder from their parents?
Correct.
Right.
And the way we test for it is blood tests. I check for a whole battery of tests, and that will tell me.
And what happens if one of those comes back positive, if you find a genetic problem in the family?
Well, first, you'd want to definitely check other family members because they need to be alerted that they're at risk too. Remember, this is a disease that patients could die from. And unfortunately, there have been deaths in very young people with this condition. The other thing is they need to take precautions to prevent the clots that they already have from coming back again. So if you have a blood clot, you already have a high risk of getting another blood clot right off the bat. Now, if you have a genetic predisposition, your risk increases significantly more, depending on which predisposition you have.
So one of the causes, genetic. Some people can have a problem with their DNA and they form more clots. What are some other causes? What are some of the most common causes of DVT or deep vein thrombosis?
Well, the other thing that could cause it, for example, is having cancer. So now when someone's older and they've never had a blood clot in their life, there's no family history of a blood clot, they're less likely to have a genetic predisposition, but it doesn't rule that out completely.
So you'd still get genetic testing, but here you're thinking maybe there's cancer causing it.
Right. I may not even check genetically if they're depending on their age and depending on my level of suspicion, but I would have a much higher index of suspicion for cancer.
Right. So cancers can cause deep vein thrombosis. We talked about genetics.
And they need to get their age-appropriate cancer screenings.
Cervical cancer, breast cancer,
and
colon.
colonoscopy.
Right.
Yes.
So let's talk about some other causes because we hear about on the news, for example, back during the Iraqi war, when David Bloom, one of the reporters, was in a tank and he was sitting for a prolonged period of time and passed of a DVT. We hear about people on airplanes. So tell us about this issue with not moving and how does that contribute to forming a DVT?
Well, there's something called Trousseau's triad. There are these predispositions. There's an injury to the vessel. There's a stasis. These are all the things.
Stasis meaning there's less movement?
Less movement of the blood. And in fact, sometimes people ask me, well, what do I do to prevent blood clots? I'm traveling a long flight to Europe, and what do I do? And I just pretty much give them some common sense advice. I'll say limit your alcohol intake because alcohol is diuretic, meaning it gets you to run to the bathroom. And it could dehydrate.
It dehydrates you.
Likewise with caffeinated products. We all drink caffeine. We're running around all day, right? Notice we're always running to the bathroom. And also to get up. I'll tell the patients to set your watch timer on the hour, every hour, get up and move around in the airplane.
Yeah, that's very important also, right? So sitting for a long time, set something like your phone or your watch or something to remind you to move. That's important.
Yep. And these things do help. And also, if they have a blood clot history in the past, I'm even more cautious. For example, someone who's had a DVT in the past or a pulmonary embolism, they have to be extra careful because they're really at higher risk for another clot.
So having a clot in the past really places someone at a higher risk for having one in the future. So let's talk about and review that for the viewers, how to prevent DVT, deep vein thrombosis, avoid the alcohol on an airplane, avoid the caffeine, stay well hydrated. As you said, dehydration is an issue.
And move around.
Move around. And this doesn't only apply to an airplane, but other areas where we may be sitting in a long car ride or a bus ride, train rides. These are important tips that you're bringing out for our viewers.
And another little practical tip, if they can't even get up all the time, I'll tell them to just do isovolumetric kind of exercises sitting in the same chair. For example, they could put their foot against a resistance against the chair in front of them and just squeeze.
So
press
squeeze
up and
down on the calf muscles.
Exactly. And that way circulates the blood, and they're not really getting up, but they're still increasing their circulation.
Great tips to talk about DVT, and I know you treat thrombosis and clots in your practice. I want to, because it's March and we're getting a little short on time, to touch a bit on colon cancer. I know you treat many, many patients with colon cancer. Tell us what is new in colon cancer treatment these days. Patients who get diagnosed with colon cancer, how are you approaching them, and what new treatments are there on the market?
Well, there's been a big explosion in general in oncology and treatments. We have what they call immune therapies. We have targeted therapies. So the first step is to know what's the stage of the cancer. So and I kind of keep it simple and divide it into early stage, locally advanced stage, and metastatic. Metastatic meaning it's spread to distant areas and really it's not curable.
So locally, that means we can cut it out, and hopefully if it's at a low stage after surgery, they won't even need chemotherapy.
Correct.
But for the viewers today, they've been seeing these advertisements on TV for some of these newer agents that you're talking about. What is new for someone who unfortunately may have advanced colon cancer?
Well, when they have advanced cancer, what we normally do now is we genotype the cancer. We run certain tests to tell us the genetics. And then the genetics then help us determine what's the appropriate treatment. So when I have a patient with colon cancer, first I look at whether it's on the right side of the colon or the left side. Some treatments are more effective on the right, some treatments are more effective on the left. I look at whether they have what we call an EGFR, what they call, I look at what they have, I look at if they have what they call RAS mutation.
So these are genetic markers, and you're able to, by location, by looking at these genetic blood tests or tests on the biopsies, to detect targeted therapies different from what we've dealt with in the past. So there's hope today, more hope at least, for patients with advanced colon cancer. So in our last few seconds here on the show, Dr. Blokh is a board-certified hematologist and oncologist here in Brooklyn, treating anemia, treating blood clots, cancers, colon cancer, as we just discussed. He has been in Brooklyn for nearly his whole life and is a fixture in our community. And I want to thank you for coming on the show. It's important for our patients to get screened for cancers, breast cancer, for colon cancer, all of the age-appropriate screenings that their primary care doctor can sort of arrange for them. So for our viewers watching today, any last pointers you want to give to them, take-home points for our viewers today?
I want to differentiate between the liquid cancers and the solid cancers. The liquid cancers, you either have it or you don't. And if you have it, it's in the blood and it's all over. For the solid cancers, timing is critical. You have to get your age-appropriate cancer screenings. On top of that, if you have symptoms, you have to see a doctor and get it evaluated. If you catch the cancer early, most solid cancers are localized. They're not in the blood yet. You could cure them. You could cure the patient with surgery. Once the cancer is spread and it's spread distant and it's metastasis, the cure rate is unlikely or significantly less likely. So timing is critical.
The message is
Seeing
early
your
detection.
Early detection.
See the primary care doctor.
Symptoms.
Ask your primary care doctor, am I due for any cancer screenings? What can I do to prevent cancer? Because as Dr. Blokh is telling us today, early detection is just so important. Thank you for your interest in the show and your desire to become more involved and educated about our health. Please visit us at medcastplus.com or on social media. Thank you for joining us today. I'm your host, Dr. Jack Braha. Stay healthy, Brooklyn.